we are now opening the very interesting session about a new technology in the field of coronary intervention. The talk will be about the DynamX BioAdaptor system, which was introduced recently, not more than 2-3 years before this time. And this system is a unique one, which is designed to restore the physiology and the normality of the coronary arteries through unique action and unique design of this BioAdaptor system. I'm inviting Dr. Arafat Mansur, who is a consultant cardiovascular surgeon from Turkey. He will present us the latest data about the randomized clinical trials, 2 years randomized clinical outcomes in coronary artery disease, patients treated with PCI. Welcome, Dr. Arafat.
Thank you. Thank you, Dr. Mazen. It's a pleasure and wonderful introduction. And thank you, Dr. Mahmoud, for... Thank you all for being here, and especially Dr. Mahmoud. And it's a real pleasure being with you during this wonderful presentation. And I'm really honored to present the last update with the coronary artery disease treatment with the DynamX. So BCI is the standard of care, and we believe that there is yet a room for improvement. We had almost 20-25 years of drug-eluting stents. Yes, sure. Thank you. Well, yeah. So yes, BCI is the standard of care, and during the past years, we believe that we reached wonderful results with drug-eluting stents, but still there is a room of improvement. And as you may see, there is target lesion failure with up to 10.8% here with the first year, and it's not plateauing for long years. And from Gregstone trial, we learned a lot about the adverse events which occurs after the first year of a rate of 2 to 3% with drug-eluting stents, and it's mainly for the strut fracture, loss of vessel compliance, vasomotion, and the capability for vascular adaptive remodeling. And we have the famous ISAR test trial, which showed us a huge rate of MACE in 10 years that can reach up to 50%. So there is a need for a new technology and a need of improvement in this field. So here, DynamX had been developed of 15 years of research and development, and the main purpose was to restore the blood flow to a vessel without compromising the acute performance, release the vessel and unlocking the scaffold by uncaging the vessel within 6 months, and return to normal vessel motion and function with continued dynamic support of the atherosclerosis vessel. So this is the design that we are talking about. It's mainly of 3 helical sinusite cobalt chromium of 70 micron, and temporarily locked and held by bioabsorbable polymer. So they are independent 3 helical strands, and they got unlocked after 6 months following the polymer reabsorption. So the research and development for this device took 15 years and some huge money to reach. And this is design number 151. So this is the first IVOSes that we have. So this is untreated artery. So here you can see the pulsation and the movement of the artery. This is the stented artery, and it's clear how it lost all type of movement, and this is the design. The DynamX. So DynamX here, you can see how it's restored all the motions after 6 months of the implantation. So we can prove this with the OCT, and you can see here how the motion is back. So you can see back the distal and systole, and each systole and diastolic blood flow with the increase of lumen area 14%, and you can significantly see these motions back. So the DynamX had demonstrated safety and efficacy with a long trials, including BioAdaptor RCT. BioAdaptor RCT was designed and published recently in Lancet, and the design was for 445 patients divided into DynamX and Onyx, Resolute Onyx, with the significancy of the target lesion failure, 16% increase in blood flow, 9% plaque volume change, and statistically significant superiority across mechanistic effects endpoints, restoration of in-device pulsatility, improved blood flow, significant lower low lumen loss and diameter stenosis, significant lower new intimal hyperplasia, and new intimal obstruction. So I will go through the trial, and this is the proof of the pulsatility. So immediately after the procedure, this is the case. There is no change in pulsation between the DynamX group and the Onyx. But 6 months later, this is, can you see? You can see here, this is the rate. This is where is Onyx 1 year later. And this is the restoration of the vasomotion 1 year later. And this is the reference point. This is the proximal part of the artery, just proximal to the device. And this is distal part. These are the two reference points. And you can see that DynamX had reached the reference points. If we look to the low lumen loss, especially in LAD, where it's benefited more from the motion of restoration of the motion, so you can see we have below zero late lumen loss with LAD, with the long vessels, smart vessels, narrow vessels and long lesions. So the mechanism of action comes into three major points. First, locked, establish the flow lumen, so restore the coronary flow by achieving high acute gain and low residual diameter stenosis. Then unlock and separate them to maintain the flow lumen, and this restores the adaptive remodeling and maintain the low diameter stenosis. And then maintain adaptive dynamic support after unlocking and separation. And this restores the hemodynamic modulation. So here is the deliver. This is the first action mode, which is the helical strands held in locked phase by bioabsorbable coating. So here the purpose is to deliver and open the lumen to establish flow lumen. And here you can see clearly how the excellent acute procedure outcome in restoring the flow. Then comes here see, sorry. Are you going to? Yes, thank you. So this is the locked phase. You can see how the significancy with the motion, and this is the unlock phase. So it's not only the lumen, the other motions are all restored for the vessel. And here the helical strands are covered totally by tissue before unlocking and separating. You can see the strands inside the formation of the lumen. So here comes the superiority of DynamX with the flow area. And this is here a unique finding with the lumen area and device area. That's we lose any of the lumen area or the device area. With the randomized clinical trial, we saw how the superiority with the diameter stenosis, especially in LAD, small vessel, and the long lesion. This is the adaptive dynamic support, and with adaptive dynamic support, we were able to restore the vessel compliance, which affected mainly with the unlocked the compliance mismatch and restore the vessel pulsatility. So this is the motion, the pulsatility test that we had performed during the randomized clinical trial. And again, you see how the restoration of the pulsatility. So in the 445 in 34 centers, 445 patients in the 34 centers, we had a patient criteria with osteal lesions, bifurcation lesions, moderate severe calcification, moderate severe tortuosity, and B2C characterization. And the primary endpoint was met, which was the TLF at 1 year. With the 2 years, that was very significant reduction with the DynamX group, and the gap was clearly significantly grown with the Onyx group. So you can see we have a 60% improvement with the results in the second year. So the TLF reduction driven by lower CVD, TVMI, and TLR, and especially in LAD was extremely significant with almost 80% reduction, and significant TFF at 2 years with almost 70%, and now we are even significant for the superiority, not only non-inferiority. And during the trial, we had a novel finding with the plaque volume behind the stent. So it was almost 12% the plaque volume increase with Onyx group, and almost no increase with the DynamX. On contra, we had a very, very unique finding with the group of hyperlipidemia group, lipid-containing lesions. So here we had a regression with the plaque, and that was very significant regression with the plaque against plaque volume increase with Onyx. So the conclusion of the trial that significant clinical outcomes at 2-year follow-up for the BioAdaptor randomized control trial with a 65 reduction in TLF. TLF event rate flattened over 1 year compared to non-plateauing events increase with drug-eluting stents. 68% reduction in TFF, and for lesions at high risk of restenosis, DynamX demonstrated, especially with LAD, significant reduction in TLF, and small vessels and long lesions, lower event rates, 0 versus 3.6 and 0 versus 2.3, confirming the first year QCA outcomes. Dynamic BioAdaptor is the first technology with a novel design and mechanism of action that restores hemodynamic modulation of the artery and delivers sustained significant clinical benefit, establishing a new therapy and potentially a new standard of treatment for patients with coronary artery disease. So, and for the BioAdaptor mechanism of action, clinically proven with excellent outcomes, the DynamX BioAdaptor with its novel design and unique mechanism of action that it restores the hemodynamic modulation, provides plaque stabilization and regression, and establishes a new category for improved therapy of patients with coronary artery disease. And this totality of scientific and clinical evidence suggests that dynamic BioAdaptor restores coronary physiology by establishing lumen flow in locked phase and maintain the flow lumen by unlocking and separation, and restores positive adaptive remodeling, and maintain established flow lumen with a low percentage diameter stenosis, restoring hemodynamic modulation by adaptive dynamic support after unlocking and separation, pulsatility, compliance matching, dynamic adaptive coronary flow, and provides a plaque stabilization and regression. Thank you. Thank you very much for this wonderful talk.
Thank you for your presentation. And I know that this study was chosen as one of the best studies in last PCR in Paris.
Yes, exactly. It was chosen. Actually, after the trial, we got awarded the FDA recognition for breakthrough technology last Friday. So FDA had recognized this as the first in 25 years implant for coronary arteries as a breakthrough technology. So I wanted to share this with you. Yes, please.
Can I thank you for the presentation. I got to ask first, what's the radial strength of this stent and the suitability for calcified lesions? And with this unlocking mechanism, was there ever migration of the stent? And can you elaborate more, how does this stent unlock in 6 months? What is?
Well, the mechanism of action, actually here we have 3 independent strands of cobalt chromium, and all of them are covered with the PLLA coating of 6 micron. So this PLLA coating remains there for the first 6 months. So with this coating, it is a unique and
like
united.
glue? It's like a gluing them together?
Exactly, yes, exactly like a glue. So the BLLA coating absorbs in 6 months and start the action. And before the BLLA coating, we assured during the trials, and we had a lot of pathologic sections, that the endothel covering all the parts of the strands. So it's all covered. And so the black regression that you ask about, yes, it's a very smart question, thank you. The black regression, actually, what we believe that by restoration of the vasomotion, mainly of these patients are on antihyperlipidemic therapy. So we believe that the calcium plaque inhibits the antihyperlipidemic therapies from being infused to the artery phase. However, with this motion, the antihyperlipidemic therapy were able to act and have efficacy with inhibiting the black tissue.
تشكرا.
Thanks,
Okay,
Dr. Arafat. First, congratulations about the FDA recognition for your portfolio there. My question to you, it looks like we've been doing wrong for our patient. If your theory is correct, then the whole idea of restenosis and us coating our stents with anti-proliferation of endothelial cells was the wrong thing to do. All what we needed is to keep the vessel motion close to normal, and then restenosis will be low, regardless of being drug-coated or not. Is that a true statement?
No. On contra, we believe on the action of what we are doing now, that it's opened the clots and keep the pressure, and with the radial force that we have, we believe on that you have to leave something behind. So this is the thing. But this something behind needs to be able to accommodate and to adapt to the vessel motion. So the thing that it's adaptive, and that's why we call it BioAdaptor. And it's now officially registered within the GMDN as a BioAdaptor. So it's adapt to the motion of the vessel. So yes, you have something inside, and you have a drug. We are using sirolimus as a drug to prevent but everything is capable to move and adapt to the vessel physiology and the motion. Yes, please.
All right.
This is really a great idea, and I think what's behind it is, or the most important point is returning the physiology of the artery.
Exactly.
And this is what we had with the absorbable stents in the past, that when we had the absorbable stent to return back the physiology, but we find that the drawbacks are more than the gain of the physiology. So the physiology was minor in comparison to the adverse events happened with the absorbable stent. I don't know how this will solve the problem. So we will talk about the stented thrombosis. I would like really if you talk to us about the antiplatelet therapy and the duration of the antiplatelet therapy with the stent, and if there is maze difference than the DS that we use now.
Well, actually, with the practice, this is the beauty of this technology. With the practice, you are dealing exactly with your daily practice. So exactly, and we have actually a good experience here with us. The practice, you deal it with your best-in-class drug-eluting stent as implantation. So you are capable to pre-dilate it, post-dilate it, side branching, overlapping. You have a wonderful 1.63 radial force. So you are capable to do whatever you do. And we have actually a big series of OCT with Dr. Göktekin from Turkey. He's now, I think he's publishing them today in Nice. So it's very capable to go through very tough lesions because of the 70 micron strands and very low profile. So you are capable to do everything on the acute phase, but the beauty that 6 months later, it will be a different thing. So it's like a butterfly that changed and became a new design. So this is the beauty of this technology, that when within the acute, you do as exactly your daily practice. So the same exactly what you are doing with your current therapy for antiplatelet technology and the implantation technology, you do the same.
How about the antiplatelets and maze?
Exactly as your daily practice. There is no special.
And maze, I mean the events. Do you have any study about how to say it?
About the study about the antiplatelet technology?
No, I mean if there is clinical outcome difference between maze.
Yeah, this is what we are presenting. Yes, this is
The
TLF.
difference in maze, I mean.
Well, actually what's accepted during the design of the trial, that the TLF is the only method that you can measure of randomized control trial. So you can measure the TLF as a predictor of the MACE. So when you have a lower TLF, that's a lower MACE. And during the trial, we published actually the cardiac death. We had 0 cardiac death against. I can share with you the publication, but yes, it's very significant, the lower. And the good thing that on the second year, there were no difference than the first year. The plateauing was very obvious against the significant increase within the Onyx group. And we chose Onyx as the only device that accepts as standard of care now and approved in 35 different countries. Yes, please.
Just to follow up on his question. So why do you think the bioabsorbable stents, not yours, but the other kind, where you maintain the blood vessel physiology, the stents are out, it did not pan out to a better results on the long term?
Well, this is why we believe that you have to have something behind. So you have to maintain this radial force. You have to maintain you have a diseased segment there, and you cannot just, on short term with the bioabsorbable yes, you had the vasomotion, but it's not enough alone. The vasomotion, yes, it's significant, but you need to have a radial force to keep pushing to block to prevent the clots, to prevent the coiling back.
Excuse me. Just one question. Since it is covered by a bioresorbable substance, so technically, is it a must to use intracoronary imaging when you deploy this stent? Is it a must for all the cases? Because intracoronary imaging. Because post-dilatation, I expect you cannot do it just like other stents. If you go with high post-dilatation, you will fracture this at the joint, because this is covered by a bioresorbable.
Well, I guarantee you now we have tens of thousands of implants. Exactly everyone, and here
I
Professor
use it
Hazan.
since 1 year in Jordan here. Many cases with post-dilatation and no fractures at all.
And we have a huge research on that there is, you can post-dilatate with because actually the mechanism of action and mechanism of locking is very, very tough, and you can post-dilatate up to 1 millimeter of the size of the stent without any fracture or any, and you can even side branch up to 3-0 balloon. So it's
in the study that they used in all the cases in BioAdaptor RCT, they used imaging.
We used for the purpose of publication, but we had done tens of thousands of stents without any treatments without any.
Thank you so much. This was great. I did not know that Dr. Mazen has been using this for a whole year, and the stent was designed by a Jordanian genius. His name is Mu'tasim Sarhan.
Yes, correct.